I am Bandile Mndebele, and today I'm actually joined by a virologist and an epidemiologist who is working stupendously, or elsewhere known in other circles as someone who makes education or public health education more accessible.
Yeah.
And I think recently we connected with Thandi Magwai, and Thandi is here to join us and help us introduce a series about how inclusion, diversity, and belonging intersect with health inequalities, or perhaps public health education. Now, for some of us who are new to the show, welcome to the show, and thank you for picking us today. Today, we are talking about why is public health and inclusion so important to belonging, shaping and informing our interactions and decisions, and also helping us understand how we can be better citizens, perhaps in a global scene. We belong to a global ecosystem, and part of that was informed by the most recent, perhaps the pandemic. Probably some of you were there. And for those who survived COVID was never easy. Isolation was also never easy. And social trust was also destroyed in the process. And I think, for example, for us as a show, we kind of picked up, for example, from the wars of DEI that emerged in post the COVID wave. Thandi, welcome to the show.
Thank you, Bandile. That's an exquisite introduction. I'm happy to be here.
Yeah.
And I think, as you've mentioned, a lot of your work and my work actually intersect quite a lot. And there are some similarities. Actually, a lot of similarities, I would say. Yeah. Thank you. I am someone who believes strongly that health education needs to be made more accessible, because I think it plays a huge, huge role in health outcomes, especially as a public health professional from the preventative side of things. It's quite a very important thing, and it is, sometimes we think of it as something that only is influenced by a person's choices or their personal beliefs or choices, but there's actually so many other determinants or so many other factors that will influence your health outcomes. I'm happy to be here today. And guys, thank you for picking us, and
welcome to the show. And I think we all caught on, right? And I think one of the things that stood out from my introduction call was, for example, number one, you had spoken about the research space within the domain, that not a lot of people are focused in that arena, and also there's not a lot of throughput or output in terms of South African footprint in the space. What attracted you? Let's start from the genesis of it. What attracted you to the space to what you're in now?
The space?
Yeah.
Oh, this answer is very long. Yeah. But for me, it was, again, I'm someone who, when you see that people are suffering, they're having all these health outcomes that are preventable.
Yes.
And that was my issue. And I have my own personal story, from early childhood, where you enter, for instance, you go to a clinic and you're seeing people struggling with basic things that you realize that actually a lot of this stuff is very preventable. And also you realize that a lot of people's health outcomes they're systemic. There's something that's so much bigger than a person just saying, look, I want to be healthy, I want to eat healthy, I want to do X, Y, Z. So you're realizing that there's all these social determinants of health. There's commercial determinants of health. So for me, I wanted to get into the space because, number one, I wanted to contribute into, just improving health outcomes, especially before they even happen. A lot of diseases, guys, do not have to happen. They're quite preventable. So it's just something that I needed to be a part of. But also in epidemiology, for instance, I just love how a lot of what we do, it's yes, there's a lot of research, but the research actually reaches the person on the ground as well. There's a lot of, it gets translated into real world solutions and real world health interventions. And I wanted to be part of that, especially as a Black girl. Also, the space doesn't have a lot of Black people in it, or at least the Black people that we are seeing. I mean, I didn't grow up seeing Black epidemiologists. And for me, I was that's something I want to do, and I'm going to do it. And
But how do you learn to epidemiology? There's teaching, nursing, doctor. But how do you find epidemiology as a Black person?
That's a good question. That's a good question. Because I used to watch those movies where you see epidemics in a movie, there's a viral outbreak and everything.
Yeah.
And I always wondered, the people that are always responding to this, who are they? What kind of job do they do?
Yeah.
And I'm so sad to say that I only found this out, I think when I was doing my honors.
Yeah.
And then I found out that there's a career that you could do in public health. Like, what? Well, what do you mean? Because you think public health, you just think health.
Or Minister of Health.
Exactly. You start to think, oh, okay, we're talking about like public health hospitals, clinics. You don't really think that there's actually an entire field of public health. A lot of what we know when it comes to health, it's clinical medicine.
Yeah.
You know, even when you go on Google or like on YouTube or whatever, and you try to find a health influencer or whatever, it will typically be a medical doctor and someone who's more like clinically focused, whereas public health focuses on population health outcomes. Clinical medicine, it's me as a doctor and you as a patient, one-on-one. And so for me, I cared more about
the bigger picture.
The bigger picture, coming up with solutions that affect people on a bigger level. And that's really how I found out about it. And it's actually not well known, especially in South Africa. When I tell people, there's a field called epidemiology. Like, what is that? Somebody even said, oh, is that dermatology?
Not the skin, honey.
This is not the skin. No. Here we're dealing with health outcomes. We're trying to improve and cut down on disease burdens and try to not... I mean, people also will say, but you guys, what do you do and everything? Like, the fact that you're not having an outbreak, a disease outbreak as it is, it's literally because of public health professionals working in the background. You know, like the whole thing with hantavirus recently. Yeah. And people were scared and worried. Oh my God, hantavirus.
Another COVID.
And another COVID, blah, blah. And I remember answering some of my friends. I was like, no, it's actually not really it's not going to be another COVID. It doesn't spread as quickly as COVID did. It's not a respiratory condition. It's not airborne and stuff like that. But it's legit because there are people in the background that are monitoring and surveilling diseases and picking them up as soon as they come through and doing something about it. And yeah, for me, that is public health. It focuses more on population health outcomes. So that's really how I found out about it. And it's interesting, guys. It's a fun practice, fun discipline. Yeah.
Yeah, and I think like now that you're opening us more into that world, I think we are also interested in that intersection, because I think for us as a show, we also focus on that intersection, that is like a bigger picture question about how belonging is changing. And one of the things that emerged or that has transformed belonging has always been health outcomes. So as you say, the social burden of health outcomes. Yeah. Because we're largely interacting with different spheres of ourselves, whether it is in health, whether it's in economy, whether it's in travel, however it is that the distance we want to socialize and engage with people, there is a cost to that. And I think one of the biggest burning questions is, why is health so expensive? Why is it that I can't get better even now immediately? Why that things are so unknown and you have to go through so much test batteries to kind of find yourself knowing what it is knowledgeable about that, and how does it inform my inclusion or my belonging to get better and to kind of like build out of the shamehood of being sick or not getting well?
That's a loaded question.
It is quite loaded. But let's start from the cost entry point. Like, why is health so expensive?
Why is health so expensive? In what context?
I think not just in the personal context, right? Because, I mean, if you think about it, or even in the country context, because, for example, when you look at how vaccines were manufactured in the COVID response, it was quite fragmented. The powers that be, or the Western countries that had the resource and the capital to mass produce and to prioritize their own citizens, kind of like rolled it out much quicker. And we were scrambling a bit to kind of like pay that attention better. And you always kind of like find a lot of classist narratives around how vaccines can become accessible, and the poor, the disenfranchised people, largely Africans, are always at the worst end of the spectrum. So it kind of like reinforces a lot of, I think, identity politics in a way, a sense of belonging about, because I'm black and I don't have means of access, I am the last bit of, and rely on charity to deserve something. Whereas, if you are looking at the other counterparts who are wealthier, you just swipe a card and there you are. So why is health so expensive?
For a lot of reasons. And I think maybe I could speak more on it from like an infectious diseases like point. And to what you're even saying now with COVID and how, like, we even saw, for instance, even our president had to kind of like put his foot down and saying, look, you guys come here, you get our data, you get participants from our countries to actually participate in research. But then you take the result and then you produce your vaccines, you produce your drugs and everything, and then they are, you know, you just, like, you end up providing them to high income countries.
Yeah.
And like for us, the low and middle income countries, for instance, we end up getting the short end of the stick. And it's another issue that's happening now with lenacapavir, this HIV injection, where the concern has been that South Africa and Uganda, for instance, from Africa, we were, as these two African countries, we had research participants that took part in both clinical trials. There was I think they're called Purpose 1 and Purpose 2 clinical trials that essentially led to us understanding how effective lenacapavir is. So you have African participants and you have even Latin America, some countries from Latin America. But then at the same time, and then the injection, there's a big pharmaceutical company that was running these trials. I don't think it's smart for me to call them out. I mean, I'm not calling them out. It's Gilead Sciences. We know it. It's not a secret. Or it's a pharmaceutical company, and it's making major strides in HIV prevention, at least from the biomedical sense of view. And so fine, coming to Africa, we get participants. I mean, and always what I've been understanding is that it's because, but you guys have such a high prevalence of HIV or a high prevalence of infectious diseases. The same thing for COVID. Like, South Africa has high COVID numbers. But it's like, well, I mean, we also are making sure that we are testing people and we are honestly reporting the numbers as we go along, right? Where there has been accusations that in some parts of the world, people were not reporting the numbers accurately. So, and then they come here and then they come with that excuse of like, well, let's do the research here because, you know, HIV, for instance, it's such a prevalent thing here. And then after that, lenacapavir has, like, they make it cheaper in high income countries, which is crazy.
Yeah.
And then, like, for us, it's more expensive. I mean, even now it's rolled out, but actually I think there's like about 350 to 450 clinics that are going to have the lenacapavir injection, which is, it's PrEP. So, and that's been the debate of why is it that
it's so inaccessible.
It's so inaccessible. And then, one of the excuses, they're like, you guys also can't. We also don't make a lot of our vaccines, guys. And we also.
Why is that? Why don't we have that capacity?
There's not much money that goes into it.
Yeah.
That's also why you have like over 2,000 medical doctors that are unemployed. But we know that we have a shortage of doctors. There's just not much. The government is not putting money into actually employing researchers and into employing medical practitioners. So then we end up having to rely on other countries to actually give us some vaccines. I think we produce like 0.1% of the vaccines that we actually use on the continent. Like we do not have the R&D capacity as it is because not much funding goes into that. And why? I don't know why not much funding is going into that. I don't know. So that's more how I could see it happening.
Sure. And I think for us as well, I think for me as well, looking at that lens from a macro perspective, I learned a lot from COVID in the sense not only like how, as you allude to, how we are viewed in the global scene.
Yeah.
And the irony of it is that Africa is always touted as the future, you know, as the future of talent, and which is statistically true.